For the purpose of this project, I interviewed Mrs. Patricia Keck, who is the Director of Student Health Services at Texas A&M International University, or TAMU for short. Mrs. Keck has been the Director of Student Health Services for over 2 years. She's been in the nursing profession, though, for 20 years. Prior to her post at TAMU, she was the Director of School Nursing for the Laredo Independent School District. Prior to being an administrator, Mrs. Keck spent 3 years in a community health clinic and spent 3 years in cardiac care. The student health clinic at TAMU is small, with only 4 full-time staff members. Mrs. Keck's staff consists of a full-time RN, a full-time medical assistant, and a full-time staff assistant. There is also a part-time physician at the clinic at 3 days a week, and a nurse practitioner who is a women's health specialist that is on campus every Wednesday. TAMU Student Health Services has a simple organizational structure. It is such a small clinic that it doesn't need anything more complicated than that. Organizations with a simple structure have a high degree of informality, low specialization, and centralized decision-making. Usually policy and procedure is communicated verbally. As director, Mrs. Keck makes both clinical and administrative decisions, and her staff often multitask to make sure everything gets done. It's important to realize that even though the clinic itself is a simple organizational structure and could function almost independently from the rest of the university, the Student Health Services is actually a part of the larger Texas A&M International University. The university as an organization has a functional structure and operates in mostly a mechanistic environment. With a functional structure, employees are working in departments based on their roles and responsibilities. On TAMU's organizational chart that I'm drawing out right now, Dr. Keck is the president, who happens to be Mrs. Keck's husband. There are 4 main vice president offices: institutional advancement, academic affairs, finance and administration, and student success. Student Health Services falls under the Associate Vice President for Student Success, the same department, actually, as recreational sports. One downside of a functional structure is that it makes communication and coordination between different departments more difficult and limits flexibility because of centralization. As you can see, any coordination between the colleges and student health is not direct. All TAMU students can access student health services because they pay a student health fee as part of their tuition money. The clinic offers doctor's consultations by appointment, routine care, and health promotion by a registered nurse. The clinic also gives vaccines such as flu, HPV, and meningitis, and performs STI screenings. Visits are free, but students are responsible for any fees associated with tests, x-rays, or prescriptions. The clinic at TAMU does provide episodic and basic care, but providing accessible basic care is only a part of the mission of student health services. The second part of the mission is to advance student health through wellness activities and health education. Since health is a responsibility of all campus and community members, TAMU Health Services integrates their work into the university community and local agencies. So you may be wondering, just where is TAMU? And who are the students that the health clinic on campus serves? In order to understand the student population, it is important to know where they come from. Laredo is situated on the banks of the Rio Grande in Webb County, Texas. Across the river in Tamaulipas, Mexico, is its sister city of Nuevo Laredo. The Laredo community has over 250,000 people, 95% of whom are Hispanic. Of TAMU's 7,000 students, 93% are from Laredo or one of the surrounding rural communities. Since the vast majority of students are locals, TAMU is a commuter campus, and 40% of the students are part-time students. Laredo, Texas actually has some of the poorest health statistics in the state. Obesity rates are high, prevalence of fruit and vegetable intake low, and the rate of death from diabetes is actually double the state average. The region has been described as a disadvantaged minority community with health, educational, and economic disparity with a long list and a wide range of health needs. Furthermore, it's been classified by the government as a medically underserved area for both primary medical care and mental health. So now that you have an understanding of the contextual dimension in which TAMU Student Health Services operates, let me explain what the goals Mrs. Keck set for TAMU Student Health when she took over as director 2 years ago. She wanted to increase the accessibility of student health services to students. The actual clinic is on the side of the student center, so a few years ago, some students didn't even know the health center existed. She also wanted to become more involved in the TAMU teaching mission through collaborative research projects and seminars, improve student wellness, and involve student health services in community outreach. During my interview with her, she mentioned numerous community agencies and organizations Student Health Services is involved in. They've collaborated on projects with the Public Health Department, been involved with both local school districts, both LISD and UISD, and Student Health Services is represented at the monthly meeting of the Laredo Health Coalition. I want to take a moment and describe to you the Laredo Health Coalition, which essentially is the resource dependency theory we talked about in class in action. Representatives from Laredo healthcare organizations and agencies meet once a month to discuss interorganizational management, complex patient cases, and emergency preparedness. Laredo has been proactive in collaboration efforts due to its scarce health resources and unique border health issues. The facilitated discussions at the coalition meetings provide an open, decentralized network of communication for decision-making and problem-solving. Often, small groups of coalition members will form to discuss specific difficult patient cases, to pool resources and provide the best and most efficient care possible. Also, the coalition offers a think tank and the potential communication channels for collaboration in addressing the region's top health priorities. In 2013, the Regional Healthcare Partnership Plan identified 5 priorities for Laredo and its surrounding communities. 1. Work to increase the region's capacity of primary and specialty care services. 2. Address the shortage of behavioral health service resources. 3. Develop chronic disease and disease self-management initiatives. 4. Emphasize patient care coordination and navigation. And 5. Address the region's need for a tertiary children's hospital and specialized children's care coordination. These priorities will require more coordination, collaboration, and pooling of resources, and major changes may need to be made. When pondering future changes, it is relevant to think about what changes have occurred in healthcare in the past. One of the questions I actually posed to Mrs. Keck was on this issue, the issue of change. I asked her, what was the biggest change you have witnessed in healthcare over the past 2 decades? Her immediate response was the switch from a hierarchical team approach to a flat team approach when providing care. 20 years ago, she told me, nurses and physicians were trained in the hierarchical framework, where physicians gave orders and nurses did not typically question them or speak up for patients. And the prevailing thought was the doctor knew best. Today, many in the healthcare industry have realized that the team approach, where healthcare professionals communicate freely with understanding that each person on the care team has a unique and useful perspective on the patient, creates better patient outcomes, and can even be more cost efficient. So, is the team-based care the best or effective enough of a solution for the future healthcare delivery for the future of the healthcare delivery industry? What other options are there? These are questions hospital executives and administrators need to be asking. Change is bound to occur. In fact, external factors are demanding change, such as reimbursement rates that are under pressure, Medicare and Medicaid enrollees are rising, mergers and acquisitions are increasing, there's increasing transparency and increasing complexity of the healthcare. We need higher value healthcare without raising costs, and interprofessional team-based care may be the answer. Interprofessional team-based care has showed positive outcomes for patients and clients. These positive outcomes are achieved when professionals work together, learn together, share the responsibility of outcomes, and collaborate together, and work to generate innovation to ensure progress in practice and service. Interprofessional team-based care is cost-effective and patient-centered. But any change introduced into an organization will be faced with resistance. There are individual and organizational barriers to change, no matter what it is. The organizational barriers to change are a lack of a change agent, inadequate financial resources or capacity for the change, poor leadership and resistance from senior management, lack of the necessary technology, or inadequate market conditions. At the individual level, barriers can be feelings of uncertainty based on the unknown, real or perceived stresses, loss of status or personal comfort zone, and a loss of equilibrium and personal power. Some healthcare providers have made the switch over to interprofessional team-based care. What strategies did they use to overcome the resistance and promote good teams? They used measurable outcomes, division of labor, trained all team members, communicated effectively, and provided effective leadership. But what does it mean to be an effective leader? What does great leadership look like? Because leadership is the key ingredient that allows an organization to be great. Should you have an authoritative style? Should you be pace setting? How about democratic? Or you could take the affiliative approach, or coercive, or use a coaching style. According to Daniel Goodman's article, Leadership Gets Results, you should actually be comfortable using any of those styles. 4 of these styles, the ones I'm going to star, create a positive work environment, whereas the other 2 create negative work environments. But there's a time and place for each style, although you probably want to minimize the amount of time you are using pace setting and coercive styles. Goldman uses an analogy in his article that stuck with me. He compared switching between leadership styles to choosing the appropriate golf club for a golf shot. Just like a pro golfer knows his club selection for a certain shot, a great leader knows what leadership style to approach a situation with. It is important to mention in this discussion that all good leaders attend to people before strategy. Leaders must make sure that they have the right people on board for the job, and they also must create a culture of discipline and accountability. What if you are like myself, a young professional, just getting your feet wet with some leadership responsibilities, and you find that you're strong in one or two of leadership styles, but pretty darn weak in the others? Don't get discouraged. You can build your emotional intelligence. Your emotional intelligence is your ability to use information about your own and others' emotions to guide thinking and behavior. And it can be broken down into 4 or 5 learnable components or competencies. Depending on what article you read, there's 4 or 5. These components are self-awareness, self-regulation, self-motivation, social awareness, and social skills. And these competencies can be worked on throughout life to improve your emotional intelligence and your ability to lead. Okay, now I've gotten sidetracked a little bit, and I would like to bring the attention back to what I observed and learned by interviewing Mrs. Keck. In my short time spent interviewing her, she came across as a genuine person, a good listener, empathetic, humble. She had a sense of humor and was both pragmatic and optimistic. All good leadership qualities. I would also like to share with you the 5 rules and guidelines she gave me as her guidelines for working with other healthcare professionals, and I liked them. Her first one is that there should be an existing level of trust between you and the people you are working with. The second is to use a flat team approach. A third, use an open and calm communication style. And the fourth, be accessible. Answer your phone, call people back, etc. And respect patient confidentiality. I enjoyed interviewing Mrs. Keck, and she's done a lot of good things with the student health services in the past 2 years that she's been there. Definitely they have made progress towards their goal of becoming more integrated within the university and the community. Mrs. Keck was able to help the student health services form horizontal linkages between the University College, the nursing College of Nursing, and the Arts and Sciences College through a research study that they did, interdepartmental research on HPV. She's also extended community outreaches and community partnerships, such as working with the Laredo Health Coalition. Now, for my concluding thoughts, I guess I'm a little tired of talking, so I'll let you read these ones. Thank you for listening.